Did you guys have a chance to have a look at the self-reflection task? So first question, what did you link it with? Direct communication. Second one, anyone? Western biomedical model. Number 3. Call a friend. Spiritual. Number 4. Is it good for a doctor to consult with family members before informing the patient about terminal illness? Collectivist worldview. Expressing pain is acceptable and I would work directly, ask for more pain relief if required. It's expressive. Number 6 is preventative health beliefs. Number 7, non-taboo topic. Number 8, individualistic. Western worldview. Number 9, modesty. And number 10, individualistic worldview. So attitudes to healthcare are heavily influenced by people's cultures. And if we look at the notion of preventative health, completely absent from certain cultures. Some countries or societies do not have as well developed biomedical or medical models like Australia does, and people see hospitals as places where they only go as the last resort. It's not a place where you go to get help or be healed, but rather as a place where you go to end your journey. So disability in certain cultures is strongly linked to karma and constitutes a shame that applies to the whole collective, and people see it as a punishment from God for some misdeeds that the person or even their elders might have done in the past. Concept of rehabilitation is also completely absent from certain cultures because people don't see the value in it, or that may not conform with their worldviews. There is a scenario that we may or may not have time to do it tonight, but in that particular scenario, a patient, 70-year-old patient, have been successfully operated. A physio came to mobilize him and he just refused to cooperate. The physio tried everything. In the end, he tried to do a bit of a man-to-man talk and went, okay, let me make you stronger. You're the head of the family, your family needs you. And the patient started laughing and said, nah, I've been serving them for 70 years. It's payback time now. Religious observances are definitely very much influenced by cultures. And you can find Queensland health guides that were developed about 7-8 years ago on providing care to people of Hindu, Sikh and Muslim background. It was done as a collaborative effort by using the clinicians from Queensland Health, but also representatives from the community. We also try to engage clinicians who were of that particular denomination. So basically it's not a checklist, it's something that has been endorsed by Queensland Health, but also takes into consideration cultural beliefs of the patients. Hospital avoidance. As I said, people are afraid going to the hospital because it's a place, it's the last stop, last stop on your journey to a final destination. Health and taboos. Gender considerations are really important when dealing with people from different cultures. Gender roles permeate everything in some cultures, and roles, men and women roles in some societies are clearly demarcated. Modesty is a huge issue, and people have certain expectations of our healthcare. Very often they may say that they can't be treated by someone of a different gender, and within reason we try to accommodate it. Of course, if you don't have a male nurse in your service, you can't accommodate that, but then you need to work with your patient and their family and see if the family can get involved in providing care such as showering. That would make the patient feel better. Really important thing to remember here, I came across a case once in a different PHN area across the river, where the only Muslim mother in maternity ward was matched with the only male midwife. And I just couldn't take that as a coincidence. There was, 56 midwives working there. There was probably 50 mothers, and some things could have been done to preempt that disaster from happening. In birthing and maternity care, obviously approach to antenatal and postnatal care is different and differs between cultures. Paternal involvement is missing completely from certain cultures. And again, we come back to your role as an educator. It's important to remember. I come from Bosnia. When I left my country, fathers were not even allowed into a birthing hospital. My father used to come in front of the hospital, mom would wave a kid on a window, and that was it. You couldn't see a kid in the first week. So it's a foreign concept to a lot of... it was a foreign concept in Australia also 20, 30 years ago. So we have to understand that people are coming from places, war-torn places where there has been no progress or no movement in the several decades to date. And all my friends, I was blessed that I was first of my friends that got a kid. I never had dilemmas whether I'm going to be there at the birth. But once I've been there, all my friends went, me, never. All of them went, and we all agree that it was the best moment of our lives. It's basically about educating, but giving fathers some room to move and giving them the semblance that they have the right to decide. They will obviously be convinced, probably by their wives, between four walls, but for us, providing that care, we don't need to antagonize them. We just need to inform them and tell them why it is good and why it should be done, but not get into conflict with them. Mobility during and post-labor also differs a lot across cultures. In my culture, there is that 40-day period, when women shouldn't do anything. The other women in the close circle, family or relatives, would be there and help them out as much as they can. Pain management is also a big issue. In certain cultures, it's considered a cowardice to take analgesia during the labor because their mothers and their grandmothers never used any analgesia, and there's that belief where people believe that being in pain somehow makes you more honest, and that had you used analgesia, you've actually cheated the natural process. So I like to label it as, belief that pain is good when there is no evidence that pain actually helps the process. Am I right here? I had this discussion with my wife when we had the first kid. It was a very interesting journey. She lost the ability to comprehend English, speak English. Only 2 hours later, she couldn't speak her first language. So it's a good indicator how much stress impacts on your ability to speak a foreign language, and there is research that supports that. But while she was responsive, she said that she didn't want epidural. Only when she became non-verbal and I could get her nodding consent for an epidural, I made that decision. She was actually thankful because, the saga actually ended up very quickly, and for her second and third labor, there was no question whether she wanted one. And it was exactly the same excuse. My mother did it without it, my grandmother did it without it, why shouldn't I? Well, because they didn't have an option. You will come across certain cultures where female genital mutilation is the norm, unfortunately. As you're probably aware, it's a punishable offense under Australian law, and I'm happy to say that those cases have finally successfully been prosecuted in Australia. I'm not going to pretend that I'm an expert on it, but there's an organization in Brisbane. They used to be called Family Planning Queensland. Now they go under the name of True, and their website is listed there. So if you need any more detail on that, they also provide training to health professionals. Do get in touch with them, and they'll be able to give you more intricate information on it.
apart from birthing, death and end-of-life care or issues are the ones where culture really impacts every step of the process. Decision-making and who decides on what is good or bad for the patient is heavily influenced by culture, and as David mentioned before, how bad news is delivered is also important. They are very sensitive issues, and basically it's important for you to educate yourself as much as you can, but then it's again the time investment, that rapport building with your patient or the family or the support system that they have in place, but it's really important to actually make that journey for them as least stressful as possible. Again, you have to comply with certain requirements and you can't change certain things, but it's really, really important to talk to your patients and to see what it is that is really important to them. There was a case not so long ago in one of our hospitals where a Muslim patient died under the cross that was hanging on a wall. So the first thing the family did when they came is they covered the cross. And they thought that would be a great problem because they would antagonize the hospital. It was a non-issue. But, it's not something that anyone did, obviously. It was at Margaret Hospital, so that's where you can find those things. I don't know if it's still the case, but this was less than 10 years ago. And they got really stressed whether they've done a huge thing, almost something that is blasphemous. It was explained to them that, yes, those things are there because of the Martyr doctrine and everything that Martyr stands for, but it's a non-issue because the patient was a Muslim and obviously it was important to them. You need to inform yourself on what their observances are. Obviously, certain cultures need to have their loved ones buried within 24 hours. I work in Logan Hospital. There's a strong presence of Maori and Pacific Islanders. They have something about taking out the body through the front door, not the back door. Recently I was made aware of a case where actually maternity services there worked with the family and enabled them to take their deceased baby home as if it was a live baby. I'm not really sure what exactly was the belief there, but I know that the feedback from the family was very, very positive, and they just couldn't believe that a Western hospital allowed them to do something like that. Obviously, things were put in place that everything is done correctly after that, but it empowered the family, it gave them some solace in the most difficult time of their lives. Certain religions do not approve of organ donation, so I wouldn't be pushing it too much. I would definitely mention it to the patient, but maintaining the integrity of the body enables the patient's soul to travel to the next destination. So even mentioning or trying to push the organ donation at that difficult time is probably not the right time to do it. Next scenario.
So we've already covered a little bit of this because this is one of the cases that I was speaking about before. So this lady had actually been in Australia for about 6 years and had been a regular attender at our practice, and she came from Ethiopia and didn't speak a lot of English, and she spoke Tigrinya. She had a long history of many different chronic diseases. She had arthritis, diabetes, mild renal failure, hypertension. When she arrived, she was both blind and deaf, which actually, dare I say, inhibited her capacity to attend TAFE and learn English, although that didn't seem to be recognised by the authorities, so she diligently attended TAFE for as long as she could tolerate. But she actually had correctable visual problems in that she had really bad cataracts. She's only about 50. And when I first met her, she looked about 70, and by this time, 6 years on, she looked about 55, so she got younger, which was actually quite remarkable. But one of the things we did do is we were able to keep the hospital connected with her, because every time she arrived at the hospital, she said she didn't want to have a cataract operation, because she didn't actually trust the hospital at all. So she came from a background where trusting the hospital was really not on, and she was alive, so she didn't necessarily need cataracts done. And she didn't quite get the fact that that's what they were going to do, was fix her vision. It was hard to believe that. Anyway, after about 2 years, she finally said yes to the fact that she was going to have a cataract done, and she did have her cataract removed. And one of the first things my nurse said when she came to visit, she said, she smiled at me. And I said, yeah, she can see you now. You know, like, it was an absolute miracle. This is one of the first things she did after she got her second cataract done. She said to me, she said, I'm going to learn English now. And, you know, like, it was all there. It was all waiting to happen. And in that time, we also got hearing aids, not only hearing aids that worked, which was actually more of a challenge, because it was quite difficult. But we did have a certain amount of problem with the hearing for most of this time, and therefore the language problem was difficult. So when we got a Tigrinya interpreter, we often found that she still didn't understand, because what we found did work, and this is one of the times when you have to actually make a judgment that doesn't necessarily fit with all the rules. So I think, I was just talking at the table, concept of wisdom has to come into the conversation at times. So the only way we could get any real conversation going was when we had a Sudanese Arabic interpreter who actually then spoke to the husband, who then yelled a kind of staccato Tigrinya that no one else could speak, only she, because that's how they communicated all the time. And in amongst photos on his phone of the food he cooked for her, we got through the diabetes management and everything else that needed to happen. So using multimedia technology in your rooms with me on the Google, not finding words and language, because really don't trust Google for language, but finding pictures of things you can and can't eat, we actually managed pretty well to get everything under control. So here we have, finally, a lady who's doing really well, has been doing fine for a couple of years, coming in with terrible sugars of 24, going, what is going on? Unfortunately, she continued to have terrible problems with the sugar and very poor compliance. And therefore the assumption was, when I sent her to hospital, that she was very poorly compliant, because she must be a bad patient, because she's a difficult patient. So this woman was also very vocal. She didn't like something, she got up and walked around the room and told you she didn't. So you always knew when you were winning or not winning. It was very, very quick, you know, non-verbal language. This lady's leaving. Oh, no, hold on, let's have a bit more conversation. That doesn't happen in the hospital system. When someone looks like they're a bit restless in the chair, you can imagine what was happening there. Oh, non-compliant person. Anyway, needed insulin. Non-compliant, therefore we just need to manage this. But in fact, it was nothing like that. In amongst all of this story, this poor lady was getting more and more restless, more and more fearful of the way the system was treating her. The insulin was difficult to learn to manage, even though she could see now. We were still having the difficulty with linguistic barriers, and the concept of numbers was not actually something, and sequential numbers was not really something that she was very familiar with, because she'd had no education. And it ended up being that really it was nothing to do with her being bad. It was actually that she had pancreatic cancer. So this is one of the things I strike all the time, is that there's the assumption that those sorts of patients don't know anything and they must be non-compliant. Whereas in fact, sometimes they've got a disease that doesn't matter how compliant you are, you actually just don't have a pancreas that's working. So anyway, when they finally did the right tests with a little pushing, they found out that there was a pancreatic cancer, and okay, diagnosis, and therefore we do a Whipple's. She recovered really well from the Whipple's, but in fact it was at operation that they decided that it was inoperable. So in fact they didn't do anything. So she had a huge cut from one end of the other that she had to heal and recover from, and they hadn't done anything. And that was an impossible conversation, because I could never quite, no one really told her, I don't think, what happened there, because I just think no one could quite explain. So anyway, she recovered despite the fact that she had the pancreatic cancer that was actually, growing at a rapid rate, and was quite happy for a while until the pain came, and she was offered chemotherapy. Now we have non-operable carcinoma that's growing at a rapid rate and with minimal language capacity and certainly no biomedical concepts. The hospital in its wisdom decided that they would offer chemotherapy. And it was very experimental, and this was a few years ago, and I said, okay, I'm going to find out about this. So I rang because she had every specialist under the sun now looking after her, so I rang the surgical people and I said, look, she's been offered chemotherapy even though you said it's completely non-offerable and it's growing at a rapid rate and it's, like everywhere you can possibly see it. What's the chance of the chemotherapy actually benefiting her? You never know. Okay, that's a good answer from a surgeon. More importantly, if you were offered it in this situation, would you have it? Like, that's really the question, isn't it? No. Like, it's like, or maybe, no, then no. So I ring the medical person who's in charge and I said, look, this is the situation with this lady. You've just offered her chemotherapy, et cetera, et cetera. What do you think? Well, would you have it? No. Okay, so that's pretty much, hit. So the oncology people, ask them too, would you actually have this? No. So here they are offering something that they would never have themselves to a lady as if it's a cure, because that's the only way you put chemotherapy. It's we're going to cure you with chemotherapy. So anyway, eventually she decided not to have it. But I felt that was incredibly dishonest. And I thought, really, it's a very simplistic response. Oh, can't speak your language, so therefore I'm going to actually give you chemo. Seemed to be the answer there. And I don't know that that's actually a really good culturally sensitive approach. But I can think that that was probably the only reason it was offered. And I doubt if you and I would actually have been offered it, and certainly we would have had a conversation around it, rather than a consent form shoved in our face and who knows how that was signed. So anyway, practical stuff, she ended up back in hospital and she was in pain, but the pain was controlled really, really easily. What wasn't controlled was the fact that no one knew what to do next because she was stuck in hospital, and her husband said, I'm not taking her home. Now, you got to remember, I just told you before, this husband is actually cooking her meals and taking photos of her food. This husband actually cares about this woman, okay, because that's the background. So why isn't he taking her home? Because they don't like hospital. Remember, I told you that too. So is there a lot of stuff that's not making sense to you? So as soon as we worked out that there was a problem, my nurse and I went up to the hospital one evening and said, okay, what's the problem? Why isn't she coming home? And the nurses at the hospital said, well, we've got all the pain under control. What we need is to get the family to decide to take her home. So we spoke to all the members of the family. They're all in one big area of the hospital. I can tell you, they're overtaking the entire chemotherapy, palliative care, whatever it was, ward. So this was a very large family with multiple other community members all together. And so we were able to do an entire survey. And eventually it went in to see my patient who was having her hair done. Good, she's doing well. And so everything's going fine. And I said, what do you want us to do? And she just screamed, home. Okay. So I spoke to her husband because it was clear by this stage that that was where the blockage was. And I said, can you take her home? And he said, no. And I said, well, why can't you take her home? And he said, because I don't know where to put her in the bed. And I don't know how to look after her. And I said, that's because that's our job and we can help. And I will come to your home and my nurse will come to your home and other nurses will come to your home and we will get a special bed and we will make sure. Her daughter, their daughter, was a nurse. And they flew in a cousin from America, if you can believe it, who was also a nurse. She had 24-hour nursing care from her family, which was completely culturally appropriate. I walked into her bedroom with the hospital bed, super comfortable, her sitting up in it, talking, God only knows how she hears on the phone, talking to Africa, to other family members, and that was how she was entertaining, listening to lots of beautiful stuff on TV with various religious music coming through. And in the middle of the floor was a little sort of petrol tin, really, without petrol, with coals and a coffee pot, and they were putting incense on the coals, and the whole room just smelt of beautiful incense. And this is the environment she was in that she did not have in the hospital. So in that context, we had to discuss the concept of dying when we weren't allowed to talk about it. And so we basically managed pretty well around that. So there was a moment when she did actually hear the diagnosis, but after that it was never said again. And she was completely happy to just die in peace at home. And she took months to die, which never made any sense because her renal function was 0 at that time when she arrived home. So I don't understand, but she was only sustained by love. And she was incredibly well cared for. One day when I was there, she did actually chuck up a little bit, and I blinked my eyes and the family had had her changed and bed stripped and remade in seconds. And I thought, I want them looking after me. because it was the most amazing care I've ever seen anyone have in their home. And so that's what we did. We actually managed really well, and it was great. And I have to say it was an absolute privilege to care for the family. The next question that my nurse asked me is, said, you know how she said she wanted to go home? Did she want to go home to where we put her, or did she want to go home? I said, what do you mean home? She said, you know, like Africa, like dumb doctor. And in fact, the answer was yes, she did actually want to go back to Africa, we discovered later, but we weren't able to get her there. She was too sick. The family did actually ask us whether or not they could actually just put a blanket over her when she was dead and wheel her onto the plane. I said no. They will notice. So it was expensive, but they did take her home, but the proper way. And that was a huge event. It was a very special thing to be involved in, and it was a wonderful thing that they were able to do that. I was sad that we weren't able to get her home at the right time, but she was very well cared for with lots of family. So there were lots of things we had to address in that story that all involved cultural issues, but the cultural support were provided by the family and us working with the family enabling that. And I have to say that the family then supported us after she passed away. It was sad for all of us. I had the privilege of going to her funeral. I can tell you that I didn't wear thongs and everyone else did, and so you could see my shoes outside because you have to take your shoes off before you went into the church. I didn't know any of these things and I learnt an awful lot. So there was, you know, thongs, Dr. K's shoes, thongs. But, you know, walking on that cold marble into the church and smelling the same incense that, you know, we had said goodbye to her with was a pretty special time. And I ended up with, dare I say, and I said to the nurses I was going to go to the funeral. As I walked into the church, I ended up with one of my nurses on either side. And I think that's something we have to remember too, that we have our own support systems within our practices, and we actually need to rely on our practices to help us give us insights around the cultural difficulties and insights around our own personal needs. And it was actually extremely comforting for me to have one of my nurses on either side of me, because I did find it a very difficult funeral. And it was really interesting because it was at the funeral, for the first time it dawned on me, she was actually like pretty close to my age, and the children were the same age as my children. And that was really hit me when I was at the funeral. I'd been caring for all the family. I knew all this facts, but it didn't hit me as to how much her life, that was so different, resonated with my personal life. And this was what the children were going through, was the loss of their mother. So, the interpretation of illness and the concepts of family and consent and the confidentiality issues, the expectations, the compliance and the concordance, I think I've sort of touched on all those issues in that conversation. So,
just like to touch on a few issues before we move to language, because we only have about very limited time to finish. This research was done in pediatric ward and an ED department, and it tells us basically that patients who did not speak English were at double the risk of receiving less than optimal care compared to those that share the same language as their healthcare providers, resulting in these three things: reduced quality of care, access to service, and their health outcomes suffered. Another issue that we all need to remember, and I was flabbergasted the other day when I found out that 61% of Australians are health illiterate. Those rates are higher for CALD population, not just for first, but also for second generation. So please keep in mind that you are an educator as well, and that the issues that the problem of limited health literacy is greater among all the patients, those from low socioeconomic background, people with limited formal education, minority populations, or persons with limited English proficiency. Someone from refugee background could actually fit all 5 categories. And it's really important to understand that they may be completely health illiterate. Another thing to remember is that they could also be completely illiterate in their language. 92% of Rohingyan women that settle in Queensland are illiterate. So producing translations for them in a written form does not work. That's why sometimes you have to resort to producing videos or audio recordings of the information we want to share with our patients. These are just some research findings on the adverse effect due to not properly addressing language and cultural barriers. We know that there are high rates of unnecessary diagnostic testings, like Dr. K said. Blood test does not solve, issues that you can't address, and that you're not solving by doing additional blood tests. Medications, incidents, and errors, simply because people are not used, or some cultures are not used to Western medication. People crush the tablets and put them in the body parts that are problematic. We know of patients that have crushed tablets and put them in their ear because they had ear pain, and instead of taking antibiotics orally, they ended up having detailed ear clean out and a 5-night hospital stay. Obviously that results in higher use of resources. We know that there are disparities in rates of attendance and admissions to hospitals. Again, go back to how people perceive healthcare. What does the hospital mean to them, and why do they come to the hospital in the first instance? Lower rates of attendance at follow-up appointments. People don't see the reason why they should come back to see a doctor if the doctor has already fixed their problem. Less use of preventative strategies in certain cohorts. In my community, Bosnian woman, 36-year-old, died of cervical cancer. She's never had a pap smear. She's never heard of it. Back home, everyone used to have it, but she must have fallen through the cracks. She was of that age group that she probably wouldn't need them before the war started. During the war, that was the smallest priority. And she came here, no one asked her about it, never had one here, passed away at the age of 36. Failure to be given relevant information about diagnosis and treatment. So if it doesn't make sense to them, they are less likely to comply with your instructions. And if you provide them with the explanation, their failure to fully understand the explanation. Always make sure when you talk to them that they actually did understand your message. Hearing your message is one thing, processing it correctly and actually understanding, comprehending what they need to do is completely different concept. This is a great scenario, but you will be sent the slides. Unfortunately, we don't have time for it today. You can have a look at the slides when you get it. There will be some questions on what cultural explanations existed for this behavior and what would the strategies be. On to the language bit. You got the form? Very often, patients come to our practices and we ask them to fill in the forms. We know that we're not asking them anything that is naughty. We know that we're doing it for the right reasons, and we just expect them to take our word at face value and fill in the forms and trust us with what we're going to do with it. People don't understand it, and it's difficult. Very often hospitals also give, forms asking people to participate in research. Can you be contacted? Well, why would they be contacted if you can't communicate with them face to face? How are they going to be contacted? So, just to emphasize the point, you all are given a form now, and I'm hoping that you won't have an issue filling it up. Those that understand are disqualified from this exercise. If you are confused and don't know what to do, ja sam tu da vam pomognem, i ako imate nekih pitanja, slobodno me pitajte. Sve što treba da uradite dole na dnu stranice, samo se potpišite. You comfortable?
Yes, I
know you are. Ako ikom treba pomoć, samo nek se javi. Sve što treba je da potpišete formu. So all I'm really after is your signature. Are you comfortable with giving me one? What you're experiencing now is what our patients experience on a a daily basis. We give them something, we know that we are giving it to them for the right reasons, and people will sign. However, you need to remember that a lot of your refugee patients come from torture and trauma background, and the problem of actually providing a signature could be a trigger for their trauma. Very often they would have been exposed to torture, and they would have been forced to sign forced confessions. As soon as they sign it, it becomes the fact. So asking them to sign something that they completely don't understand could constitute a trigger for their trauma. So always try to never ask people to sign something without the presence of an interpreter. Always book an interpreter and get them to explain the rationale of why signature is sought. So that brings me to our interpreting bit, which I will really have to be quick with. What do we have? 5, 10? Yeah. Thank you. So why do we need to use interpreters? To enable our patients to fully understand the messages, to empower them, but also to exercise your duty of care that you've communicated effectively with the patient. It's also a basic human right to be understood, and it empowers the patients to actually feel like adults again, because one of the worst feelings that a non-English speaking migrant experiences when they come to this country is the feeling that they are becoming infantile again. They can't express themselves. Our language enriches us, enables us to operate at a certain level, and when we have limited language proficiency, obviously it impacts on our self-esteem. When do we need to use interpreters? Whenever issues of medical significance are communicated. It's up to you to gauge when the issues that you are communicating in your medical practice are not of medical significance, but if you think you need one, you're probably right. How to book it, we'll look at that in a minute, and I'll just talk you through certain things. So, if patient does not speak English and you don't speak their language, it's highly recommended you use a professional interpreter. Some patients may speak some English, but more likely than not, they may not understand the medical consultation. Again, I'm repeating, interpreters are there for mutual benefit, but purely legally speaking, it's there for you to exercise your duty of care. You cannot, hand on heart, say that the patient has understood you if you don't share the communication medium. Please always use an interpreter and use a teach-back technique. There are fact sheets available on big health websites, which will provide you with a link later on that provide steps needed to use teach-back technique, and then a separate one using teach-back technique with the presence of an interpreter. They will sometimes come up and show you a card that's available on the resource desk over there that says, I need an interpreter in a certain language. So please use that as their signal that they need help with communicating. And these are the scenarios when you absolutely every time should have an interpreter. Seeking informed consent, as Dr. Kay said, it's not an isolated case. Very large proportion of all the cases that end up in the court of law in this area are about informed consent. The fact that someone came with a BYO interpreter, that you used a family member, does not indemnify you from actually not fulfilling your duty, and that is making sure that the patient has understood you. Settlements are either 6 or 7 digits, I've heard of recently, and they happen on a regular basis down south. Not because they have processes worse than ours, simply because they have probably 10 times the demand of Queensland. If there is a crisis, book an interpreter if you're dealing with complexity and if you're assessing patients' compliance. More information, detailed information on how to access free translating and interpreting services are available in the folders available at the resource desk at the back. But basically, medical practitioners can access this free interpreter service if they are delivering Medicare rebatable services in a private practice.
Nurses, reception and other practice support staff can also access the service when working with medical practitioner, and pharmacies to dispense and provide information and advice about medicines and healthcare. Also some other NGOs, some other agencies including NGOs, real estate agencies are also part of this MOU between the federal government and the funding bodies, and they can access interpreters free of charge as well. There's something called Doctor's Priority Line. You can access it on that number above, and it basically gives you a priority over all others in a queue, because it's assumed that your issue may be more urgent than someone else calling to pay the bill with Energix. It's available 24/7, and it's for private medical practice staff only. You need to register to get this national client code, to receive that individual code, and once you have this code, you can use it every time the interpreter is requested. If you are a doctor working, if you are a doctor working across different practices, you'll need a separate client code for every practice that you operate from. This is just how the booking portal looks. So you can book it online. You can book either telephone or on-site interpreters in advance to ensure that the interpreter is available for consultation. There is no clear evidence that indicates that on-site interpreter is superior to telephone, but if you think about it, you're depriving yourselves of all non-verbal clues, non-verbal communication, which we all know constitutes at least half of our communication, by utilizing telephone interpreter. Telephone interpreter is more than suitable for certain types of consultation, but for some it's grossly inadequate. If you're operating in mental health, please never try it. I had the luxury of actually doing it a couple of times, and how do you interpret via phone to a person that's hearing voices? Anyway. TIS has a huge pool of interpreters across Australia. Sometimes your patients will be reluctant to use interpreters simply because of the privacy issues. There have been really bad cases in the past where confidentiality was not, the confidentiality clause was not honored by the interpreters, and the word got around within the community and people are reluctant to use interpreters at all. However, please always offer them an option to get a phone interpreter and tell them that you can get an interstate interpreter. You never have to identify your patient. You can call your patient confidential, and for their sakes and purposes, they don't care. Reassure them that it can be from interstate, it can be from Western Australia, and usually it works. If they still refuse, document it. If you don't document it, you haven't covered yourself. There's a separate program for allied health professionals, and it's available through PHNs in the Brisbane area, and provide private allied health professionals with free access to interpreting services as well. Okay, this is very quickly on how to work with interpreters. It's really important to be mindful of the time. The time does double, if not triple sometimes, but it's of crucial importance to actually invest that time in building rapport with your patient. In order to optimize time management, it's good to have your thoughts organized. Use the simple language, because interpreters are a very diverse bunch. You will have people who are barely educated formally to people who are actually university professors in Australia. So it's good to always go with the lowest common denominator and use the simple language, because you're communicating to your patient and you can't and should not rely on an interpreter re-pitching your message at the right level. Use even pace and use short sentences. Some interpreters may be perfectly comfortable with you talking concepts and them interpreting segments of information that are longer than a couple of sentences, but the majority are not. So work with an interpreter and basically use them as a part of your multidisciplinary team, because in essence they are there as a support staff to you to enable you to perform your duties to the best of your ability. Allow time for them to interpret and speak to the patient. Use first person. Please don't address them as he or she, because they don't need further disempowerment. A good interpreter, even though I said before, should never omit or alter any message. I will admit that I always change the speech to first person speech, and within two exchanges, both the doctor and the patient will start addressing each other directly. Look your patient in the eye, don't look at the interpreter. A good interpreter is an invisible interpreter, and they shouldn't be the part of the communication. They are the conduit of your information and should never be a filter. They are there to provide you and the patient with a smooth communication flow. Please make your questions simple, don't confuse them, don't use double negatives either, and make the instructions relevant to the patient's case, patient's life. Make sure that they understand, whether it's via teachback or any other way that satisfies you, as you have to do with an English-speaking patient. The fact that we share a communication medium does not guarantee understanding, so it's always important. Whatever you do in a monolingual setting, do it across cross-cultural barrier as well. Don't assume that conversational English is enough to operate in a complex medical environment, because people are dealing with emotions, and obviously there is enough research that shows us that a person's ability to speak foreign language diminishes when they are stressed or in pain. Really important thing to remember is not to use family members. That is, in a perfect life, you will sometimes have to use family members for certain things. What you really should never do is use children. The case that freaks me out to this day, and it happened about 12 years ago, is when an outreach sexual health clinic from the district I work in decided that a 6-year-old girl, linguistic competence and maturity levels would be sufficient to interpret the issues of a gang rape of her mother back in Africa. Do not use Google Translate. The consequences could be fatal. Google Translate is great if we are stuck in Tokyo and we don't know where to go. It may help us, but it will not help us in healthcare settings. Other government departments are jumping on it because it's the best thing since sliced bread. Well, it's not. It's rubbish. That's my bread and butter, and I will continue to advocate that Google Translate should never be used in healthcare context until they teach computers how to think and do a breakthrough in neural networking. It's simply not happening. They've been stuck in the same place for 10 years, and it's not moving along. If it works for languages that you don't need. Reasonable levels of translations are probably available in major languages, German, Spanish, French, but that's not your target audience. In my language, it's an absolute rubbish. And it's a language that is spoken by at least 25 to 30 million people. So languages that some of your clients will speak, are spoken by several 100,000 people, not more. You need to remember that certain things just don't translate well across languages. Concepts are non-existent. And if you think about recent developments in Western medicine, how long did we have concepts of palliative care? Okay, a couple of decades?
Yeah.
More?
Yeah, 2, 3.
So people have left their countries. A lot of people that are actually settling in Australia now would have been in refugee camps or living as displaced people within their countries for 20 to 30 years. There's a concept that is known as cultural freeze. They take away the picture of the world like it was the day when they left their country. They're not aware of the changes that happened in the meantime. So I have a huge problem explaining or translating palliative care to people from my country. Occupational therapy. What is that? Allied health. So basically sometimes, if you use 2 words, I may need 2 minutes to explain it. good interpreter should let you know what they're doing, because every side conversation should not happen in a vacuum. The third party should always be involved. Same applies if you're asking questions of an interpreter. You should also, if the interpreter is not doing it independently of you, you should remind them that they should keep the patient informed, because it's a human nature that we jump to a conclusion that usually they're talking about us. Whenever you find yourself in a room of people speaking a different language, what's your first thought? They're talking about me. And they're not. More likely than not. But we all assume the same thing. So especially in a consultation setting, it's important to keep everyone informed of what's being discussed there. What's the interpreter help?
Yeah, I think we'll skip the video.
Yeah.
And interpreters help. Sometimes interpreters... That's my addition to the slide. So sometimes, just occasionally, interpreters step out of the role of being an interpreter, particularly when they're actually health trained. And some interpreters are actually doctors, nurses, and they go on about, you know, all the things that I apparently forgot to say and add them in. And sometimes they even admonish the patient and how terrible they've been, and I didn't quite get round to that and wasn't actually thinking of doing that, and the patient may or may not want to come back to see me, and it wasn't actually me that said those things, and they don't know that. And sometimes the interpreter also doesn't actually say the right thing, like in that, you know, partly that's a health literacy thing, but it can come down to whether or not I said pear juice or not, because what's a pear? Like, so there's all sorts of different concepts that sometimes are helpful or not helpful that happen in the and we just need to be aware that sometimes when we're trying to work out why things didn't happen, we can go back to what happened in the last consultation. Chances are we've got a different interpreter this time, and we can sometimes unpick the fact that there was an error and correct that error. So that's, I just wanted to mention. We were going to show you a video, but we haven't got time to do that. Aware that we're running out of time.
But I guess we'll send the link to...
Yes, we'll send the link so that everyone can see it. I would recommend that you see the video and the link, because it really emphasises why family members are concerned. And I think we've all been in a situation where it seemed like everything was going really well, and then we realised, if we actually understand what was happening, that it wasn't going well at all. Oh, sorry, I feel like I've taken... No, I have to say that in preparing this talk, I have really appreciated Angel and David's expertise, because we've come together a few times and as you can see, we're going to and fro in this session, and it's been a really interesting time preparing all this, and I hope you've appreciated what we were trying to sort of convey in a very short period of time has actually been, you know, over a decade for each of us in this area, trying to navigate the health space that's actually cross-cultural and cross-linguistic issues. So Andrea tells me I have to say that, where are we? Lack of expertise. That sometimes there is someone in your clinic who might be the Spanish-speaking cleaner or whatever. Please do not grab them from whatever job they're doing and let them do whatever work they're doing, and don't sit them in your consultation. They're not a trained interpreter. They're possibly from the same community as your patient, and they're not the people that you should be using. You need to use a trained interpreter who can actually do the job well. So it is something that has happened and often happens in the hospital setting, and it can make people feel really happy that they're helping, but it seriously is dangerous potentially for the patient. And I can say there's actually research now that's coming out of ACT that actually shows you that Google Translate is really dangerous, even though the patient thought it worked well and the doctor thought it was great and everyone was happy with it. When they actually untranslated all the conversation and what was happening, everyone realised that they actually got the complete diagnosis and treatment wrong, even though everyone thought they were navigating the space well with Google Translate. So that's a really scary situation. So basically, if you find that the patient seems unhappy or the interpreter seems restless, chances are something's not right. Unpick it, work it out, and then you can actually keep going then. If the patient keeps returning, then obviously there's a problem with the language as well, or the communication. I mean, this happens even when there's no linguistic problem. If the patient keeps coming back, there's something wrong, and we've got to work out where the problem is. It might be cultural, but it might also be the language. And if there's a lack of concordance, in other words, your patient is just not doing what you're told, it might be that they've actually got a very good reason not to, and it might be that they actually didn't get told what you thought that they should have been told because it wasn't actually conveyed to them properly. So I do see them as issues where there may be a cultural or linguistic divide that you need to actually navigate more effectively than what you managed before. And then ultimately there's an awful lot of resources that are available for you, and I can't emphasise enough how the Refugee Health Network Queensland, I Google it all the time at work because there's always something that I need on that resource. In fact, every time they show me the Google Analytics of this, I go, oh, half of that's me again. And they go, but it's from lots of different computers. I go, yeah, I'm at all those computers. So anyway, I just can really, really recommend it. So hopefully you've enjoyed what you've learnt tonight. Hopefully you can give us some really good feedback about what we can do to improve things for the future, because we're really trying to craft this specifically for the health space. We've had other people, for the primary care health space, we've had other people trying to present when it hasn't been a crafted message, and so hopefully we're sort of getting there closely so that in the future we can get it right next time.